Hello and welcome to everyone who have registered so far, and my name is Kim Pearce and I'm the coordinator of the Cancer Support Group Leader Program at Cancer Council New South Wales. Cancer Council New South Wales acknowledges the traditional custodians, both past and present, of the lands on which we live and work. And tonight we invite you to come together and talk about anal cancer in gay and bisexual men. Our priority to the Cancer Council's Information and Support Division is to empower and support people affected by cancer so that no one need face cancer alone. And we acknowledge here the lesbian, gay, bisexual, transgender and intersex communities. We are an organisation that's for all people and all cancers. Before we get started, I'd like to take you through some housekeeping, so it'll make an easier journey with us tonight in this webinar and look at some of those issues. So during the webinar, if you'd like to ask either the panel or myself a question, please use the chat facility, which is located on the bottom left-hand corner of your screen. And if you experience any difficulties hearing the sound throughout tonight's event, please feel free to listen via the telephone by dialing the 1800 number provided in the chat box and then enter the passcode provided. And our first speaker is Steve Leppard, and he is presenting for about 15 minutes, and uniquely we're trying something different this time. There will be a bit of space to actually have ask questions of Steve at that time, or for you to comment. So I really, for those who are interested in the consumer story, would encourage you to participate in that space. And also today's event is actually recorded, as we have been mentioning in the media and in the email releases. And for anyone who is registered, you will be sent a link after the copy of the recording. So please don't worry too much if you get distracted by the chat box, as you can watch the presentation later. And if at any stage you need to speak to someone urgently, please do not hesitate to contact Q Life Counselling Service, which is the 1800 184 527, or traditionally the Lifeline Counselling Service, which is 13 11 14. And this support, both supports are available 24 hours a day, 7 days a week. So let's get started. Firstly, I would like to introduce our panel. Steve Leppard, here he is to my left in the room. We're all in the room together tonight, so welcome, Steve. Andrew Grulich, who is to my right. He's told me how to say his surname a few times and I still got it wrong. Apologies, Andrew. And then down the table is Richard Hillman. And I will introduce them for each of their, and thank you for the waving, guys. And monitoring the chat box, then you can't see her, is the manager of the Cancer Support Group Unit, Lorna O'Brien. And you can say hello to her in the chat box, and she will be adding any comments, etc. during the presentations. And finally, 2 points to help ensure that everyone has the opportunity to gain most from the webinar. We ask all participants to consider following these ground rules, and just to keep looking in the chat box, be mindful of others seeing your views and comments. And also just be aware that 2 of the presentations tonight are quite clinical, people with immune deficiency and heterosexuals. And our guest speakers, presenters tonight, are from the Kirby Institute at the University of New South Wales and Sydney University, Sexual Health. And they are working together as a team conducting the study of prevention of anal cancer. And Cancer Council New South Wales, building on the success of the Kirby Institute work, is supporting this collaborative team with a strategic research grant to reduce the morbidity. Second webinar in the project focusing on gay and bisexual men. And now to get started, our first presenter is Steve Leppard, who is a survivor of anal cancer, and he will share his personal experience with.
Thanks, Kim and Lorna, and the Cancer Council of New South Wales for asking me to speak at this webinar, and for the Aurora Foundation for their generous donation to enable it. I was diagnosed with anal cancer in 2013. At that time I was 49 years old. I had been gay for 49 years, and I had been HIV positive for 21 years, which put me in a high-risk category for anal cancer. For a number of years before the diagnosis, I'd actually suffered from a chronic anal fissure, so I had symptoms in this area, and I forgot to mention at the time of my diagnosis, I was also a medical doctor. So I was monitoring my symptoms and seeing my GP regularly for checkups. I had pain on defecation and some bright red blood after passing bowel motions, which was typical of an anal fissure. And we did decide together with my GP that I should have colonoscopy given a family history of bowel cancer. And that was clear, and that was repeated a couple of years later. And one other thing that I was doing at the time was, and this might not be for everyone, but I was occasionally performing a digital anal examination on myself. And as it turned out, a few years later, I discovered a lump on my own self-examination, which I discussed with my GP. It was firm and about a pea size, and I was a little concerned about it, so we agreed I should be referred to a surgeon. And unfortunately, the surgeon wasn't particularly concerned about the lump, but he did manage to cure my anal fissure with a new form of treatment with Botox injections, which proved very effective at reducing the muscle spasm in the anus. And of course, there was lots of jokes afterwards about having a wrinkle-free anus after my treatment. So I then was symptom-free for about 9 months, but then the bleeding returned, and this time there was no pain. And again, I examined myself and discovered a very large hard mass, which was extending well up into the rectum. And so further testing showed a squamous cell carcinoma, positive for the HPV virus, that it had spread through the rectal wall and into the pelvic lymph nodes. So for the medical people on the call, that was a stage 3B anal cancer, which is quite advanced local cancer. And the treatment given at that time was radiotherapy. Excuse me. 6 weeks of radiotherapy combined with chemotherapy in weeks 1 and 5, and that's the standard treatment for most cases of anal cancer, unless it's very early or very late. And the radiotherapy is a new version of radiotherapy. It's called intensity modulated radiotherapy, which did get rid of some of the side effects from the radiotherapy that was given previously, but even so, it was still very painful. But the final result of that treatment was really disease was gone, and I still had my normal bowel function from top to bottom. So the treatment of anal cancer in early stages is actually very effective, and one of the messages of this webinar, I think, is early diagnosis and effective treatment is really vital. Unfortunately, because my cancer was so advanced locally, I did have a recurrence quite quickly after the radiation, and so 9 months following the completion, I required the next stage of treatment, which is a major surgery, abdominoperineal resection, and a permanent colostomy. That's a very big operation. A lot of reconstruction needed, and a major adjustment to my lifestyle. I really wasn't happy about going ahead with that surgery, particularly as I had worked with a surgeon back in 1990 who performed that operation, and so I'd assisted at that operation when I was an intern, and was familiar with the nature of it. But it took a little bit of adjusting, but I have to say that a year down the track, I am free of cancer and I'm well and healthy, and having a colostomy is really quite easy to manage. It's quite surprising. So I can't say that that's going to be the case for everyone, perhaps, but my experience, it's just one of the steps that was needed for me to cure myself of cancer. So I'll give myself the best possibility of a long-term cure of cancer, and we'll see how that goes. One of the things that I wanted to bring to this webinar is really more about the psychosocial aspect of acquiring this diagnosis, and I'd like to just sort of compare it to many people on the call may identify as gay men, and for me, I came out as gay in the late 70s when really it was not an acceptable thing in society to be gay, and there was gay rights movement was in its infancy, and my family were not happy about it, and so there was a lot of shame around that aspect of my personality, of who I was, which resolved slowly over many years, and is well and truly gone these days. And then early 90s, being diagnosed with HIV was a similar thing. It was a newish disease at that stage. There was a lot of misconception about its nature, and the treatment was very early and not proven to be effective. And a lot of shame arose around it. It was the gay plague, and everybody, gay men were dying. And I have to say, I was very lucky that I did contract it at a time when I was able to receive treatment. Very grateful for that. But it took me many years to actually overcome the shame associated with that, and I'm sure many people on the call would have some uh, similar experiences in terms of society's attitude to that disease, which again is changing, thankfully. And then being diagnosed with anal cancer recently had a similar feel to it, but I don't know. I guess I was used to getting over this aspect of shame and what society thought about it, because for me, I've let that one go completely. Um, and the thing that I noticed though is that now that I'm starting to speak about it, and I actually couldn't speak the words anal cancer for a year after the diagnosis, but now it seems to be flowing out pretty easily. I found people were very uncomfortable when I was speaking about it, and you could sort of see them not being really wanting to engage, and it's really the anus is the part of the body that is most disowned. It's just it's a shameful part that doesn't get talked about, and we've all got one, and it's just another part of the anatomy that acquires disease, and so it seems to be my role at the moment just to be bringing this story to the public and getting it out there, and working with some of these other great people that are doing excellent work in this field, and the Cancer Council, just to bring a little bit more light onto the diagnosis of anal cancer, that it is increasing and that it's treatable if it's caught early. So I'm just here to say that there's nothing shameful about this diagnosis, and that it's just a part of life which has its ups and downs, and I'm grateful to be here. Thanks, Kim.
Got the mute button now. Thank you, Steve. And we just move into that next slide because I was just looking to see what was happening in the chat box, and we were just starting to get some recognition of particularly the powerful language you were using at the end there around you did actually lose the shame, or that completely. I mean, and acknowledging to be able to come tonight and speak freely with a very open community all across Australia. We had some of the registrations, and I was just wondering if there was anybody in this space that wanted to put any question to Steve in the chat box at the moment. I can see lots of thank yous, and I can see lots of appreciation and acknowledgement from people and participants about gay friends they've lost, and how powerful this sharing is. So I think your presentation's been respected. So thank you very much. And for time's sake, because we will have more questions at the end, we'll move on. And can I welcome Professor Andrew Grulich, who is presenting approaches to preventing anal cancer, and he is a HIV epidemiology and prevention specialist from the Kirby Institute, University of New South Wales. And welcome, and over to you, and I'll turn my...
Thank you, Kim. Thanks for the opportunity to speak here tonight, and a big thank you to Steve for, this is such a stigmatised disease, and we really do, through work such as this, need to lift the stigma that surrounds this disease. It's ridiculous that it should be stigmatised. We're just talking about any other organ of the body, and that's how we should be dealing with it. So with that, I'll move on to my presentation, which of course is going to be a lot drier than Steve's. What I'm going to talk a little bit about is how common anal cancer is in the general population and its causes, and then I want to focus most of the talk on prevention. And in the epidemiological field, we talk about primary and secondary prevention. So primary prevention being the prevention before anything starts, and I'm going to talk about the human papillomavirus vaccine. Secondary prevention being screening and treating precancerous lesions. So in terms of how common anal cancer is, this is a condition which is increasing in virtually every population where it's been studied in the world. I should say in the general population it still remains quite an uncommon cancer. The graph you see here is cancer rates in Australia. The red line is for women, the blue line is for men. And so the first point to note there is that in the general population, this cancer is actually more common in women than it is in men. The exception to that, as you're about to see, is in gay and bisexual men. And you'll see in both men and women, rates are increasing with time. And as I say, in every time people have looked at this around the world, it's been happening. We're not entirely sure why this is, but it may well be due to changes in sexual behaviour over time. So one of the very remarkable things about anal cancer is that it's extremely highly concentrated in just a few populations, and this table summarises those data, and I'm going to use, I hope, my laser pointer here, and so please follow the red dots as I'm talking. So compared to the general population, women with previous disease of the anus and genitals that's due to HPV, so that might be cervical precancer most commonly, are at 5 to 10-fold increased risk. People who receive an organ transplant, that's most commonly a kidney transplant, are at 5 to 10-fold increased risk. The reason for that is that those people have to take immune suppressive medication for their life, and that immune suppressive medication helps the virus that cause anal cancer get out of control, and hence that increased risk. Now, gay and bisexual men who don't have HIV are at increased risk, and we think that's about a 5 to 20-fold increased risk. And HIV positive people who are not gay and bisexual men are at increased risk. So we're talking there about women, all populations of people with HIV apart from gay and bisexual men have increased risk. And that's because, again, the immune suppression, the immune deficiency, can let the virus get out of control and cause anal cancer. Now, in HIV positive gay and bisexual men, those two risk factors come together. So we have both immune deficiency and increased exposure to the virus, the human papillomavirus. And in this population, we see really very high risks of a 50-fold relative increase in risk, with the actual incidence being between 70 and 130 per 100,000. And to put that in perspective, that's roughly the same as the rate of colon cancer in the general population, which makes it one of the very most common cancers in this population. So although it's an uncommon cancer in general, it's very highly concentrated, particularly in HIV positive gay and bisexual men. So the cause of anal cancer is human papillomavirus. This can be detected in more than 90% of cancer cases, and we actually think that it's probably 100%. This is the same virus that causes cervical cancer in women, and for which women are screened after the onset of sexual activity. The same virus can cause cancer of the penis, the vulva in women, and some types of throat cancer as well. And those HPV positive types of throat cancer are very much on the increase as well. Now, HPV is a sexually transmitted infection, and it's by far the most common sexually transmitted infection, such that essentially everybody who's sexually active will acquire HPV during their lifetime. So most people who get HPV, in most people who get HIV, the condition resolves with no treatment. So that's good news, and please, nobody should go away from tonight thinking that if they have this virus, they will get anal cancer. It's a very, very small minority of people who have HPV infection who get anal cancer. It's very transmissible. The virus can hide in places like under fingernails and on the skin, and so condoms provide only very limited protection. Some types of HPV, and we call these the low-risk type, cause genital warts, and other types, which we call the high-risk types, can potentially cause anal cancer. And about 80% of anal cancer is caused by a single HPV type, which we call HPV-16. There's over 100 HPV types overall. So the research that the Cancer Council has funded, and the approach that we're taking as researchers, is to look at 3 levels of prevention. So we can think about preventing before infection, and that's basically vaccination, mostly at adolescents. We can talk about screening for either HPV infection or the high-grade precancerous precursor that it causes, but there are some issues with this which I'll raise in just one moment. And thirdly, we can talk about tertiary prevention, which is about early diagnosis and curative treatment of early cancer. and it's, as Steve mentioned, it's the early diagnosis which leads to much more acceptable treatment and less toxicity. Now, in terms of HPV vaccination, this is a very busy slide, and I want you to ignore all of it except for this figure here. And these are the data from a randomized trial of young gay and bisexual men aged 18 to 26 who were randomized to either receiving the vaccine or a placebo. And this is a 75% reduction in high-grade cancer research, precursors. So this is really fabulous news for the future generations of gay and bisexual men, because vaccination early, mostly before the onset of sexual activity, will greatly reduce the risk of anal cancer. So who should we be vaccinating? So in Australia at the moment, since 2007, we've been vaccinating all women, and that's of course to prevent cervical cancer, and we have a catch up to the age 26. And this program is justifiably world famous. It's already resulted in enormous reductions in genital warts and in precancerous lesions in women. Since 2013, Australia was the first nation in the world to introduce publicly funded vaccination of young boys as well. At high school this is done, at 12 to 14. The issue with vaccinating old people, people older than 14, is that the vaccine works best in people who are not currently infected with this virus. And for that reason, and because the virus is so common in sexually active people, we don't vaccinate men older than 15 routinely. But there are some arguments, and this is a building argument, that it may be worth vaccinating adult homosexual men. Why? Well, unlike women, we continue to see high rates of new high-risk HPV infection well into the 30s, 40s and 50s. And that is a hint that perhaps vaccination might be effective at these older age groups. In terms of existing recommendations internationally, in the US, they do recommend vaccination up to age 26, and we're doing some work in Australia to try to lobby authorities to pay for that. In fact, in the Australian Immunisation Handbook, there is a recommendation the vaccination of adult men who have sex with men be vaccinated, but this is not funded by government, and that's clearly an issue. And in the UK, there is an interim recommendation that adult men who have sex with men up to the age of 40 be vaccinated, which would clearly be a very hopeful intervention even for men well into middle age. What about screening? These next few slides touch on some of the problems with screening. It has been suggested we might screen for HPV in gay men as a way of detecting who might get anal cancer. The problem with this is that HPV is so common. So about 3/4 of HIV positive men and over 1/3 of HIV negative men have HPV. So it's not enough on its own to be measuring this, because these are very high proportions which don't decline with age. In terms of the precancerous precursor, I should say potentially precancerous, which is sometimes called SIL or AIN2+, again, these are very common conditions, 30 to 40% in HIV negative and positive gay and bisexual men. We're finding in our studies in Sydney that it looks like a lot of this disease goes away on its own, and so will not need treatment, and that's good news, and it's perhaps not surprising, because it's only a couple of percent of positive and negative gay men who would ever get anal cancer. So clearly most of these men, these 30 or 40%, will never get anal cancer, and therefore wouldn't need treatment. The rates of progression to cancer of about 1 to 400 per year in HIV positive men are much lower than the rates of progression of the cervical precancerous lesions. Despite this, based on cervical cancer screening, many people in the medical field have advocated for anal cancer screening with an anal pap smear, which is very similar to the cervical pap smear, and Richard Hillman's going to tell you a bit more about this later, and high-resolution anoscopy, which is microscopic examination of the anus. You would refer people who have any abnormality on the pap test, but these tests are less accurate in the anus than they are in the cervix, and treatment is very suboptimal. So because of these limitations, we currently do not recommend anal cancer screening using pap smear testing in Australia. We are looking at in the study of prevention of anal cancer, or the SPANC study in Sydney, at the natural history of these precancerous precursors to see if we could define a small proportion of these men who might benefit from treatment. The condition, the high-grade condition, is so common that it's clear that we can't treat it all, and most of it will never progress. And the problem with treatment is that it's currently unproven. It's much more difficult than treatment in the cervical precancerous lesions. And so in the absence of a good screening test for precancerous lesions, then what can be tried, and Steve touched upon a self-examination version of this, is digital anorectal examination, where a doctor examines using his finger the complete anal sphincter to look for evidence of early cancer, with the aim of curative, low toxicity treatment if it's diagnosed early enough. So I'm going to stop there and hand back to Kim. Thank you.
Thank you. Thank you. And I'm open. So thank you very much, Andrew, for that in-depth presentation around prevention, and just acknowledging here with some of the registrations we did get lots of questions, and I appreciate that input around preventative questions. And I think a lot of those, and I hope those who are participating tonight will have picked up on that. So we probably won't spend time over those, because I feel those issues around what are the tools that can be used for prevention, what's the place of HPV, have all been responded to. So now I'd like to welcome Professor Richard Hillman, who is an Associate Professor from Western Sydney Sexual Health Centre, which is part of Sydney University, and he will be presenting the clinical perspectives. And I'm now handing over to
Thank you, Kim, and thank you, the Cancer Council, for inviting us along to talk about this very important issue, and particularly thanks to Steve for giving such a touching, very personal experience. And I appreciate how brave it is to do something like that, so thank you very much. So, as we've heard, anal cancer is relatively uncommon in the general population, and one of the consequences of this is that general practitioners and other mainstream healthcare providers may have limited awareness themselves, and sometimes gay and bisexual men may actually know even more than their healthcare providers. As Steve in particular has mentioned, the stigma and embarrassment associated with anal health may inhibit both patients and healthcare workers from raising the issue during a consultation. Nobody likes talking about anuses, and sometimes people have to take the initiative to raise the issue. So, as we've heard already, anal cancer is often present late, and at least some of this is because of the embarrassment issues, but also some cancers arise a few centimeters inside the anal canal, and so it takes a while before they become noticeable to the individual with the condition. The commonest symptoms with anal cancer is bleeding, a lump, some pain, and a sense of incomplete evacuation of the bowels. However, a number of much more common symptoms may have very similar symptoms, so the symptoms themselves aren't necessarily a very good indicator of anal cancer developing. And hemorrhoids, for example, is extremely common. It's the commonest cause of anal bleeding, and is absolutely nothing to do with anal cancer. Anal warts are quite common, particularly in the gay community, and again they have a very complex and quite loose relationship with anal cancer. And as we've heard from Steve, anal fissures are quite common in the general community and are unrelated to anal cancer. And perhaps as a word of advice, it's the change in symptoms that are often the most important. So if someone will have bleeding from hemorrhoids occasionally when they wipe themselves, but if they suddenly notice a change of frequency or extent of bleeding, that may be a sign that you need to take your symptoms a little bit more seriously and seek advice. So this diagram here is meant to represent the anus, and as you can see here, the anus is really 2 to 3 centimeters inside the anal opening, and the site most commonly associated with anal cancers is this junction between the paler outer skin on the outside and the soft fleshy skin inside, rather like the lips of the anus, which are 2 to 3 centimeters inside that area. And you can understand if a lump develops inside, it takes a while before they become apparent to the individual. Okay, so what can I do about it? I think the number one thing as it's become apparent is to be aware. And as Andrew's already mentioned, HIV positive gay and bisexual men are probably the highest risk, and even HIV negative gay men need to have an awareness that this may be an issue. Unfortunately, as we all get older, the risk of anal cancer increases quite significantly. Anal cancer is rare under the age of 35, but does gradually increase, as do many cancers as we get older. I think it's really important for people to understand that it's not just partners who practice receptive anal sex who are at risk. As Andrew mentioned, the underlying cause, the HPV, is extremely easy to acquire, and so sharing a virus is very common, and so you do not need to have receptive anal sex to acquire anal cancer. Please be proactive with your healthcare providers. They need some help sometimes. They may be embarrassed to raise the issue. But once you raise the issue, I'm sure they'll be very keen to hear your concerns and to learn on the journey with you. Please have any new anal symptom fully investigated. As Andrew mentioned, there is an argument that HPV vaccination is helpful, particularly if you're under 26 years of age. And one thing which is important not to forget is, like many cancers, cigarette smoking is associated with anal cancer, and if you can stop smoking, that is a significant benefit to your likelihood of developing anal cancer. So anal cancer screening programs are not generally available yet. However, as Andrew has already hinted at, they're potentially really quite simple. You can see here from Andrew's diagram, anal cancer at this end here is where we're talking about. So we're talking what is called tertiary prevention. And the cancer screening program which is potentially of value is something called digital anal rectal examination. So what is this? It potentially allows early detection of small cancers. The finger pulp is really quite sensitive. We can detect something as small as a grain of rice. So a trained individual can potentially pick up a cancer at a very small stage, and at that very small stage, simple treatments are possible with considerably better outcomes. So we are beginning to recommend it annually for all HIV positive gay men over the age of 35 years of age, and for certain HIV negative gay men who are particularly at high risk. One of the additional benefits of having the digital anal rectal examination is it also allows the prostate to be checked at the same time, and I'll explain that a little bit more in a second. So I suggest that you ask your healthcare providers whether they're familiar with DARE. If they're not, then there are now training resources available for them to upskill. As Steve has already mentioned, it's possible, if you're comfortable doing it, to perform the DARE on yourself or get your partner to do that. So this is what a DARE looks like in the clinical room. You can see on the photograph on the left-hand side, someone's lying on the left-hand side. We've got a gloved finger with standard lube, and then it's inserted gently into the anal margin, and it's rotated firmly through 360 degrees. In the schema on the right-hand side, you can see that what happens inside, that the anal canal is able to be reached quite easily with a gloved finger, but it can also feel the prostate. And that's why people get the additional benefit of a prostate examination. However, it's not without its challenges. I think most commonly we get what are called false positives. In other words, a lump is noted, but it turns out to be not a cancer. And these are caused by anal warts, hemorrhoids, some normal variants, what we call papillae, and sometimes scars and fissures can be picked up as well. Perhaps more worrying, though, are the so-called false negatives. In other words, that the cancer is there, but it's missed. And that's probably due to inexperience and really speaks to the need for training of our healthcare staff. So that's anal cancer screening programs. But perhaps we really want to bring the story forward a bit and see whether we can identify people who are at very high risk of developing cancer, so in other words, pre-cancer screening programs. Again, unfortunately, none are generally available, but the models which are being explored at the moment are based on the highly successful cervical cancer screening programs. And as Andrew mentioned, we are currently looking at this in a number of research programs. So again, going back to this diagram, what we're looking at is looking at this area here, for example, where HPV, the probable causal infection, is acquired, and to see whether we can identify individuals who might progress to anal cancer. Again, they're non-routinely available. The testing is relatively straightforward, and indeed I'm aware that one or two general practitioners are beginning to offer this. However, I think one needs to be extremely cautious about having this test done. It is based on understanding that HPV is necessary for the development of anal cancer, and indeed cervical screening programs are beginning to shift away from the pap smear towards HPV detection, and it can be done on a simple anal swab. However, as Andrew has already highlighted, HPV infection is extremely common, it's very easy to share, and that most HPV does not lead to cancer. However, it might be that persistence, in other words, the continual presence of HPV over certain types of HPV over time, may be an important indicator. So what about this area here where I put the red dot? What can we do about detecting high grade, the pre-cancerous stage, the stage at which in a small minority of individuals might go on to develop anal cancer? Well, we have two options here. One which is based on the cervical pap smear called an anal pap smear or a CHAP smear if it's done in men, and the second thing called a high resolution anoscopy or HRA. So again, anal pap smears are not routinely available, and I would not recommend that people have them at this stage until we can work out exactly how to interpret the results. It can be done on a simple anal swab specimen, and the changes down the microscope look very similar to the cervical changes. However, abnormalities are extraordinarily common, including the so-called high grade, much more common than the cervix. In addition, because of the anatomy and various other considerations, the pap smear, even if it's negative, does not reliably exclude a serious problem internally. And even when high-grade lesions are seen on the pap smear, it by no means does it mean that that person will develop cancer in the foreseeable future. And what we're increasingly realizing is the term high grade is made up of a bunch of different conditions, some of which most of which are fairly relatively benign, and only a small minority will progress to cancer. So what does an anal pap smear look like? On the left-hand side there, you can see it's just a bottle and essentially a moistened cotton wool swab, which is inserted into the anus. You can see on the right-hand side there, and move gently around the circumference of the anus up to a few centimeters inside. This is a picture inside of the anus, and you can see one of the challenges we face in this area. There are lots of folds inside the anus, and this makes it quite easy for us to miss lesions which are hiding in these little nooks and crannies. And on the right-hand side there, you can see what's called a high-grade pap, which, as I said, is almost identical to that we find in the cervix. So that's anal paps. What about the next stage? If when we look at the cervical model, there's something called colposcopy, where doctors usually will have a close look at the cervix under the microscope, and this indeed is how high-resolution anoscopy developed. Again, it's not routinely available. In fact, it's only available in very few numbers of centres in Australia, and requires a high level of skill, and essentially is a research investigation currently in Australia. What we do is we insert what's called a proctoscope, which is basically a disposable plastic tube which has been lubricated with some local anesthetic into the anal canal, so we can start looking at this area here. And this is a high-resolution anoscopy room in action. You can see the individuals lying on the left-hand side, and that has the advantage that they can actually see what's going on the screen. Now, once the scope has been inserted into the anus, We then shine a light into the anus and have a microscope here, which is led through a video camera to the screen here. And most people actually are interested in seeing what's going on inside them, and we can explain what the issues are if there are any there. So that's high resolution anoscopy. And this is what it looks like down the scope when we've applied certain dyes, something called acetic acid. You can see here again the folds I mentioned to you before, which make it technically challenging to make sure we don't miss anything. And on this higher power view here, you can see this whitened area. And this is a characteristic of so-called high-grade changes. And again, these appearances are very similar to what we find on the cervix. And here is a biopsy of what's called high-grade disease when we take a biopsy from that whitened area. But it's technically very demanding. Abnormalities are extremely common. We may miss things, and most high-grade lesions do not lead to cancer. In fact, what we found is a significant proportion of high-grade lesions will clear without any intervention at all. And of course, the procedure is uncomfortable, it's pretty embarrassing, and there's some bleeding post the procedure. So we need to be very careful and highly targeted about the use of high-resolution anoscopy. So in summary, I think it's really important for gay men to be aware of potential risks of anal cancer if they're 35 years or older, particularly HIV-positive gay men. And I think be brave, open up a conversation with healthcare workers, such as your general practitioner. They will appreciate it by and large. They may be thinking how to address the issue, and if you, by raising the issue, you may be able to start a conversation. Any new anal symptoms must be investigated, especially bleeding, pain, lump, or a sensation of incomplete evacuation of the bowels. Again, first port of call is always your general practitioner. Dare to dare, both to yourself, your partner, and maybe even introducing the concept to your GP. Some screening programs are under evaluation, but we are still very much at an early stage in understanding how to develop a screening program. And if there's any program going around that needs a volunteer, then think about volunteering for it. As I've already mentioned, some GPs are really quite not familiar with this technique, and we've got a few training videos now available on the web. Thank you.
Thank you, Richard, for that very insightful clinical perspective and very graphic and therefore I think really bringing out, probably assisting with that issue around those who do sit with shame around changes that are happening to them around their anogenital area and not feeling comfortable enough to speak with their GP. I am aware that there's been a couple of questions going on in the chat box, and I wouldn't mind bringing that up first before we actually address the questions that are up on the slide, and mainly because Steve referred to it around his own digital rectal examination, and Richard, you were sort of mentioning it. It's an area, I just wondered if you could comment on the future of teaching self-examination. It sort of seems to resonate for me around the issue of breast self-examination that we've realised is not what we thought it was 20 years ago. So if you could comment on that, please.
Well, there's been a little bit of research done this down in Melbourne, and it's still at very early stages, I think. It is quite a confronting issue, and I think the first issue we have to deal with is raising the possibility of doing it. I think I would encourage people to explore their anus because, as everyone's mentioned, we all have an anus, and just like any other part of our body, we don't need to be shameful about it. I think the more you understand your own body, the earlier you are likely to develop an awareness of any symptoms. You need to be reasonably flexible. I think that would be the right word to do this, and also slightly creative. What I suggest you do is, in the first instance, get gloves, disposable gloves. Make sure you've got plenty of lube. Lie on your left-hand side to start with, and then start with your right hand and gently insert it into the anal sphincter and get a sense for what's there and if there are any abnormalities. The anal lining should be nice and smooth. It shouldn't be uncomfortable. It shouldn't be sore. Occasionally it's slightly uncomfortable. And then once you've explored 180 degrees, then you effectively have to flip over onto your other side and repeat the exercise with your other hand. Unfortunately, we're not that flexible to be able to do it all in one go. But I think it's knowing your own anus, knowing what's normal for you, enables you to detect any changes. And again, I want to emphasize it's change in symptoms as well as findings, which is often the first and most important indicator that something's going wrong.
Mm.
On some sort of a regular basis, and they might want to, timetable it for, the 1st of January and the 1st of June every year, or something like that, because you do have to get used to the way your anus feels, and you're looking for a change, and particularly a lump that's a change. The other thing I'd say is that if you try this, and if you're in any way worried, then get straight to a doctor, because your doctor is going to be able to do it. Most doctors will be able to do it far better than you can, although it is the case, I'm afraid, that particularly if you're seeing doctors who don't have a high gay male caseload, then they may not be terribly familiar with the technique. And at that stage, you'd have to consider going to a doctor who sees more gay patients, I think.
Mm. Thank you, Andrew. Steve, did you want to comment there, seeing you brought the issue up and just, that
my personal technique
disclosure
is in the
was...
shower, squatting. It's much easier. You've got running water available. I personally don't use a glove, but I do use lubricant. Just, it's fine for me. And then you're ready to have a wash at the same time. And I don't know, it's like giving birth. Squatting for me is a much more, physiologically natural position. Thanks, Kim.
Fair enough. Thank you, Steve. I think that's, I don't know whether I'm looking over at Lorna, just wondering whether anybody else has put anything up that might be relevant to that. Thank you, Andrew. And just when we get towards the end, I will highlight that there is actually a resource sheet that's attached to the webinar when you receive it in the next week. That document is there, and there is the bottom line link that's there, and you can go in and view any of the understanding anal cancer and the prevention information. And so thank you to Simon for bringing that up, and for Andrew for noticing it, noting the importance of the material coming out of that area.
By all means, have that discussion with your partner.
Thank you. Yes. And I'm sitting here naively, not being gay, bisexual, but just imagining, or I'm wondering about the anus is such a huge part of gay and bisexual sex, and assume that touching, examination, well, I wouldn't use it in a clinical respect. Is this going to come up? Is this something that will make it easier? Or I'm querying even the question, I suppose. Go for it, Steve. Put me in my place.
Oh gosh, yeah, as on the playing field, and for me, it was a significant part of my sex life, and but for other gay men, it might not be. So I think there's all the whole a better understanding of the anatomy of the anus and the prostate than perhaps.
That's been happening in the chat box, which I think Steve has responded to, is each individual experience is different, and shame has been an experience for some and not for others. So what is that point of difference? And it's down to individuals and their comfort about talking about their body. But yes, I would have assumed there's probably a greater aspect around shame, particularly in the issue of slow to present. I think, and just listening to your presentations, that's probably one of the biggest challenges, is that people, if we can excuse the pun, literally sit on it too long with symptoms that they're thinking will go away without actually having the comfort to go to their general practitioner.
Story of having a clinical symptom which led to them seeing a doctor, and then with a very substantial gap before diagnosis is a common one. And I think if men are concerned about a change in their anus and their doctors are just monitoring them for a long time, then if they're really concerned that there is a change there, they should ask for a referral to a specialist proctologist.
Yes, yeah. And I noted a couple of people have commented and they wish they'd watched this webinar before their diagnosis of anal cancer, and I think the links that Richard has put up, they're your YouTube clips, aren't they? And I've got them on the resource flyer as well. So yeah.
And generally they miss the first 10 centimeters. So a negative colonoscopy does not exclude anal cancer. And I think a lot of people have that misconception.
Okay, thank you. Just looking at our time, we've got about 6 minutes left, and so we should come back to the questions that have been, I have posted that came up fairly early. And so this first one, I'm feeling like the stats were discussed, but if Richard or Andrew would like to comment on that.
So look, if that, I think that's a question about hepatitis C. HPC isn't quite right, but if that's a question about hepatitis C co-infection, hepatitis C has no role in this. It's all about human papillomavirus.
Thank you for that. And what's happening for those going through it and those who are in the healing process? So what's happening in the supportive care area? And if I can comment here, for Lorna and I in the Cancer Support Unit at Cancer Council, it's an area that we are looking at, particularly hosting this webinar tonight, where anal cancer is a rare cancer, and we know that there is a lack of psychosocial support that's directly linked to people with anal cancer. But our Cancer 131120 number, our information and support line at Cancer Council, the staff there have undergone the ACON inclusive training, where they're all registered for this webinar tonight, again for them to feel more comfortable and confident in speaking to callers and discussing these issues. So we are trying to move into that space, and one of the things, and leading into the next question, it's actually my question to you as participants, if you are living with a diagnosis of anal cancer, are you interested in joining an online group for gay men diagnosed with anal cancer? And what I'd like you to do, and I've put it on the slide and you'll get it when you get the link, is to give me an email on that kimp@nswcc.org.au. Steve, when he first came to us and was happy to be participating in this webinar, he's very passionate about trying to change the landscape around support and get involved in a support group. And I think rather than the face-to-face support groups that I'm more involved in, we're moving into the online, and it will allow us to reach out to men all across New South Wales, across Australia, through our colleagues in Cancer Council, state and territories around Australia. We'll be able to recruit and bring into that. So please, if you're participating and you would like to engage with us, and probably when Steve and I do get together to look at this and start looking at recruiting, we will actually utilise the database of people that have registered because you've said to us you're interested. So if that's all right. So I'm just conscious, is there anything else, Lorna, anybody? It looks like there's something for Richard.
Thanks. Look, I think there's still an awful lot more research needs to be done about whether just a receptive partner. I can certainly tell you that individuals who have never had receptive anal sex can have developed anal cancer, and I think that's related to what Andrew was saying earlier on, that HPV is incredibly infectious, and the normal sexual practices, even without anal sex, can result in the transmission of the virus. So just because you're always a top does not mean you're not at risk of anal cancer. And I think the message very much is, if you have any symptoms, get them investigated, and if you feel able to do so, then explore the possibility of doing your own examination or get your partner to do it.
Okay. Yes.
This comment about receptive men may think that some anal changes may be related to how they have sex. I'm not sure if I'm getting his point exactly right, but if he's saying that that the anus may change after sex and that that may make men think they have cancer, you know, if there are small wounds, if you like, after vigorous anal sex, for example, then those things should get better. They should improve over a period of weeks or months. So it's not that you should be worried about every tiny little symptom from your anus, but if you have a symptom that's persistent and not getting better, that's a time when you really should get yourself checked out.
Great.
You've been heard by your healthcare providers, then seek a second opinion, because as I mentioned earlier on, because this condition is relatively uncommon, a typical GP may not necessarily be up to speed with it, and so think about getting a second opinion if you are not happy if you don't feel you've been heard.
Thank you, Richard, and thank you. Can I just going to move on to this last slide, and it is where I've taken the opportunity to ask our three presenters just to send me a key point. And I think really Andrew's last statement is part of that summary of what has been discussed tonight. Early diagnosis is critical. The current research will inform any future assessment of whether anal cancer screening will be performed in Australia, just to put that out there from the Cancer Council. And this last statement is what Steve put forward, and I think some of the questions around that have come up around, is the gay community aware of this as an issue? What are we doing about advocating and getting it out there? I just think this statement is from the heart. Humans come in many different varieties with widely different views and beliefs. Cancers come in many different forms with widely differing causes, treatments and associated issues. Anal cancer is just one of those many forms and should be viewed in the same way as every other form of cancer, without prejudice or stigma. Thank you. And on that note, I'm just going to show this last slide. I think we're there, is the resource, just highlighting the resources that you'll find when you receive the webinar. But there is that bottom line link again. Cancer Council's also been involved in research called the Rekindle Project, and it has been recruiting for over the last year, and it is looking at an online study, and gay and bisexual men are well introduced into this software or this program, talking about sexuality and communication issues. So I would recommend that to you. I'm just come over there and acknowledging the work that I'm doing is the Cancer Support Group area, and I know that Colin is on the webinar tonight, and he's actually he and his colleague Jude actually run the Northern Rivers Lesbian, Gay and Bisexual general cancer support group. So it's unique for the state to have a general cancer support group run by two colleagues who identify as gay and lesbian. Also, the Cancer Connections area, which is where we will be introducing the online community. So that's cancerconnections.com.au is available space, but we are actually going through a repurposing space at the moment, but it was where we will come back to you. And finally, the support and information. Again, I mentioned these at the beginning, that if there are any of this information that's triggered anything for you tonight and you would like to seek support, Cancer Council has the 13 11 20 number, which is Monday to Friday and 9 till 5, and you can get quite clinical information that you can access through them about anal cancer, as well as the two support lines, Q-Life and Lifeline. And in conclusion, can I remind everybody that please, there is an exit survey, and we would really appreciate if you could take the time to give us some feedback on your experience in the webinar tonight and the value that it was for you. So once we close down, which is just about to happen, I will formally say good night again, and thank you to Richard, Andrew and Steve. Thank you to Lorna over in the chat box, and particularly to Gavin, who this is his second webinar with us in the LGBTI area. Thank you for the time you've given us tonight. I really appreciate it. And thank you everybody for participating participating. The chat room's been fantastic.